Welcome to the Interventional Glaucoma Podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. This episode is the second part of our special two-part series where we investigate advanced insights, complex cases, and real-world experiences that put expertise to the test. This episode goes beyond the basics, diving into in-depth cases and expert perspectives. Let's get started.
Thank you so much for joining us today for this special episode. These are all guests that have done more than 100 Elios procedures. You're all centurions, masters of the Elios wand, waving that wand to create magic. So I'm super delighted. Anselm, any patients that you would be a bit cautious about doing Elios on?
I guess these are the same patients I also would be afraid or would be of caution in other procedures. What does it mean? So the anterior chamber must be deep enough, you know. So I do a lot of standalone procedures in pseudophakic patients. And coming back to your first question, if you start with the angle surgery as a first procedure, for example, it's a good idea to start with pseudophakic patients because you have not to care about the lens, you know. Otherwise, we speak about open angle glaucoma, early glaucoma, or intermediate glaucoma. No secondary glaucoma due to neovascularization, whatever. I do not perform Elios in traumatic cases because we do not know exactly what's going on with all the outflow system. I guess there are three aspects I would keep in mind. The first is efficacy, as you talked about, and the side effects, and the question in the sequential surgery of glaucoma procedures, and you mentioned it already. So I guess there are no really absolutely significant differences between the different procedures in angle surgery, for example, iStent or Elios or Hydrus or whatever. But there are no side effects. So I have never observed side effects in ELT procedures, you know. And in contrast to these procedures using an implant, as I mentioned, it's not of importance if one or two spots are not really in place, because even 8 might be enough. But if one or both of the eye stents are not really well placed, you will not have efficacy for sure. And this is the advantage of the Elios procedure. You are independent of that. And the second one is, as you mentioned already, the anatomy of the Schlemm's canal and trabecular meshwork is all well prevented. So you can combine another procedure after ELT, for example. This is in contrast to Cahoog or trabectome.
It's interesting because there's been a bit of conversation or comparisons with trabectome and Cahoog, which are obviously both deviceless MIGs. If you look at the MIGS space as a whole, it's probably more populated with deviced implants, and certainly in the UK, probably more towards deviced implants prior to Elios. And therefore, it's a bit of a paradigm shift for us as surgeons. I may be speaking with a slightly UK-centric hat on there. A question to Dan and Anselm at the same sort of time. Have you had any cases that stuck in your head? Obviously, you've done over 100 cases each now that have stuck in your head saying, wow, you know, that patient has just done so well. And then you've gone back and thought, was there something about that patient, whether it was a high pre-op IOP or a certain level of disease or type of glaucoma? Maybe I'll go to you, Dan, first of all, and Anselm ponders that. Have you had any sort of spectacular results and any characteristics that may guide you towards these sort of mega successes?
Yeah, it's the kind of holy grail question, isn't it? I wish we all could do that pre-op. And Nils mentioned that there's patients with damaged distal outflow, which we wish we could spot, but we can't. So some of it is trial and error or a bit of luck. But yeah, we've all had those super responder patients we've talked about before, where you just get this amazing response that almost takes you off out of breath, really. I think it depends on how you measure it. So you're right, the ones with the highest intraocular IOP pre-op will come down more. There's that regression to the mean. So an outcome of 15 or 16 is about as good as you're going to get. And obviously, if you start at 18, it won't come down that low. But there are very few patients who start with pressures of 35, 40 because they're always on medication beforehand. As part of the clinical trial we're doing, we're washing patients out, and actually they're often in the low 30s pre-op. And actually, we're starting to see the real power of the device, or all devices, when you wash out patients first. But yeah, I wish there was a way of knowing. What I do really like about Elios is sort of the confidence and the reproducibility or reliability it gives me. I'm seeing that I'm getting a good response, maybe not always an amazing response, but a good response in a lot more patients. I can be more confident that I'm going to achieve that than I have done before.
When we treat hundreds and hundreds of patients as we do per year, we are really treating a wide heterogeneous group of patients. What we're trying to do with MIGS is trying to create a reproducible outcome in what is very much a heterogeneous group of patients with groups of pathologies. And I think Elios does take a big step forward in creating that sort of more homogeneous effect, which, every surgeon looks for. Anselm, what are your thoughts on patients that when you look at them on the slit lamp or look at them at their pre-op characteristics, you sort of start licking your lips and thinking, yeah, you're going to do really well.
Yeah, yeah. And in fact, there's no absolutely clear clinical characteristic that might give the information that this is a good candidate for Elios to have a very, very huge IOP reduction. So we are just analyzing our data, and up to now I have no clear clinical characteristic preoperatively to have this information about the efficacy of the procedure. That's why I always tell the patient, if we do the angle surgery, we clean up the manhole cover, so that's to tell the patient, we might get IOP around 15, some of that, but there might be also IOPs around 12, also sometimes a bit higher, so that's why the answer of that question you gave, it's really really important, but in my hands I have no answer till now for that.
Yeah, and I think Dan had taught me something when we've been doing some UK-based webinars, that I think Dan is more aggressive in stopping medications post-operatively than I have been across multiple MIGs. And I think I've always erred on the side of caution and safety, and therefore continuing the drops and then dropping them down. But Dan made a really good point that actually sometimes even when you stop the drops and you think their pressures are going to creep up into the 20s, for example, when you see them at the next visit, actually still controlled. So I think for me, over my 100 cases, I've now got a lot more confidence about being a much more aggressive in reducing medications and actually allowing the Elios procedure to do the heavy lifting rather than trying to create some sort of hybrid where drops and Elios are doing that. Dan, I'm sort of paraphrasing what you were telling me. What are your thoughts?
Yeah, I think we've both come to the same conclusion, aren't we? That when you add a drop to a patient, a drop naive patient, you know what you're going to get. If you add a prostate, you're going to get a third off their pressure, roughly. And but when you take it away, you don't get a third back on again. So the maths doesn't work in reverse because you've changed the dynamic, you've taken the lens out, you've touched the meshwork. It's a different entity. I think if you don't look for drop reduction, you don't get it. You could happily sit at 16 and say, "Oh, I'll leave these on 2 meds," but you might find that you can get off, pressures of 18 off all meds. But I would be cautious about doing it too early. I think I initially stopped everybody, like you do, Anselm. But I do feel that actually for a week or so, you probably want some medication on board. Let the AI settle, let the steroid kick in, just let it calm, and then sort of week 4, week 5, week 6 is when you start to tinker. But I would definitely encourage, if you don't try, you're not gonna know.
Nils, I think you had a point.
Yeah, Gok, I was going to say it depends on your indication. The more comfortable you get with this procedure, the more advanced glaucomas you might start to treat. And of course, in those patients, you're less likely to really stop all medication. So the number of medications can be misleading. It is a function of the severity of glaucoma itself. And we're treating more advanced glaucoma oftentimes because patients want to avoid filtering surgery. And why not? It's a safe procedure. I have not had devastating pressure increases as I've seen after other angle surgeries. So I'm quite safe to give it a try and just let those patients know that they might still, very likely will still need drops or even need to proceed to other surgeries rather soon.
Fantastic. Well, thank you guys. Nils, Jose, Anselm, Dan, thank you so much. So many cases under your belt, so much experience and pearls that you have shared with all our listeners today. So thank you very much for your time.
Thanks, Gok.
Pleasure. Bye-bye.
Perfect.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision is a wholly owned subsidiary of Bausch & Lomb. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlaze GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.